All right, next is digoxin. Now, we've been talking about this a lot today. Digoxin. You like that? So, okay. All right. It is what we call a cardiac glycoside, right? This originates from a plant called the foxglove plant, but they also call it the digitalis plant. So that's why it's called. Good job, everyone. All right. So it does a whole bunch of different things. So the MOA, as you can see, it's got a lot. So let's start it. Blocks the ATPase activity in the myocardium. What is the myocardium?
The muscle part.
The muscle. So what is ATP?
The energy.
It's energy, okay? And what does ACE mean? It's an enzyme. So it's blocking the enzyme that breaks down ATP, meaning it gives your myocardium more energy so it can pump harder, okay? Because the main job of digoxin is to increase contractility. There's not very many drugs that do this. Now, we did learn 2 on our code sheet. What were the 2 drugs on your code drugs that increased contractility of the heart? Dopamine and, settle down. Dopamine and, it sounds almost exactly the same. Dopamine and I know. Dobutamine. Dopamine and dobutamine. And then, but those we titrate those. You have to be on an IV drip. Like that's an ICU drug. Digoxin is the drug for cardiac contractility that you can take at home. Go with? Okay. It decreases norepinephrine by stimulating the vagus nerve. What's the job of the vagus nerve?
The way you talk.
I know it's something about sympathetic.
Parasympathetic. It's your calming down nerve. So if you have anxiety, you need to stimulate your vagus nerve to calm your ass down. Okay. So it decreases norepinephrine. What's the job of norepinephrine? It's one of the fight or flight, right? Which increases heart rate and increases blood pressure. So if it blocks that, then what do you think digoxin does? Decreases heart rate, mostly heart rate. Okay. So if we look at the therapeutic effects, what does digoxin actually do? Because this is a lot of MOA. We're talking a lot. Actually, go to the green real quick. Okay. It is a positive inotrope and a negative chronotrope. Okay. So let me explain what that means. Positive inotrope means it makes the heart do something. It's positive. It's doing something. So it increases the force of contraction, which increases cardiac output. Isn't that what we want for our heart failure patients? Okay. It is a negative chronotrope. What do you think negative means? Take something away. We're an MOA.
No, it's like
right there.
Oh, okay.
Okay. So it's a negative chronotrope. Okay. If negative means we're taking something away. So it decreases the heart rate. Yeah. So digoxin does 2 main things. Increases contractility and decreases heart rate. Those are the 2 main things it does. Okay. But it does some other things too, Avi. So therapeutic effects, it's going to increase contractility and decrease heart rate. We already established that. It increases cardiac output. That makes sense because it increases contractility. How does it decrease edema? It does not make you pee more. I haven't talked about the kidneys not at one time. How would it help to decrease edema?
Pull the fluid back.
Why do people get edema?
Too much fluid?
Where? From what?
Well, if they have like an increased contractility, then the blood is pushing
forward instead of backward. And the backwards blood flow gives us edema. That's why patients with heart failure have edema, because their cardiac output is so bad, so that blood backs up. So the way that it decreases edema, it's not a diuretic, has nothing to do with kidneys, but it gives you more cardiac output, so there's less backup of fluid. Now, it will increase your urine output. It's not a diuretic, and it does not work on the kidneys, but how would it increase urine output?
Because your heart is pumping.
Your heart is pumping more. Your heart pumps out the... Y'all, no, what the? Your heart pumps out the... Oh, shit. Oh, no. How does your heart pump blood to the rest of your body? Ma'am, no. Y'all, for fuck's sake. Yes, the aorta. So your heart pumps blood out of the aorta, down the... If y'all say ventricles or aorta one more time, I'm kicking y'all out of here. Oh, okay? Aorta, sorry. Goes out of the aorta into the... No, what the fuck are y'all talking about? The portal veins in the liver. Yes, in
Yeah.
your
After we say
abdomen.
abdominal
Abdominal
Yeah.
aorta. It goes
Aorta.
directly from the abdominal aorta to the
get the renal.
renal
Through the
arteries. Thank
renal
you, Ashley,
arteries.
for saving us all. And that goes right to your kidneys, right? So if you're, I'm glad we videoed this. This is great. So as you're, if it's increasing your cardiac output, that's a whole bunch more blood coming out the aorta, down the
Abdominal.
aorta, and directly to your
Aorta, renal,
kidneys. So
kidney.
that's how it increases urine output. It's not a diuretic, but blood is actually going forward instead of backwards. You with? Help us, Lord. Digoxin. It's a great drug. Does not prolong your life, and it increases the mortality rate if you're a lady. I'm sorry. What? So if you're a lady, I wouldn't take digoxin because if my heart failure didn't kill me, this medicine will. No, not taking it. That is insane, y'all. The like this is so stupid. They're like, oh, your heart's failing. It's not going good for you, but let me give you a drug that will increase your death rate.
Well, I guess.
Sir,
Okay.
no, no, sir.
Well, I guess I would consider digoxin as a memorable misogenic drug. I guess.
Yeah, yeah, oh, yeah, misogynist. Yes, 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 yeah. They're like, oh, we love him and all women. Thanks. Things already try to kill us too much. I ain't about to go down with digoxin. Okay. All right. Important things to note. There is a lot of pharmacokinetics for digoxin. So your first lesson that we did in here is going to come back today. So I hope you remember it. All right. It has a narrow therapeutic range. What does that mean?
That means that you can go into drug toxicity or it could be ineffective.
Very good.
So you need to draw the peak and trough so you can know
Or
what.
instead of peak and trough, we can also just draw. You have two options when you have a narrow therapeutic range. You can either draw peak and trough, or you can just draw the serum levels, right? We can just draw serum levels. And since they're at home on this, we can't draw peak and trough.
Okay.
But you were right about narrow therapeutic range. They can go toxic or ineffective very easily, right? Okay. So that means we need to draw levels. You've already learned your digoxin levels. Digoxin levels are the same as creatinine and lithium. Very good. Now, if you go to the UTMB, they use a different level just for heart failure, and I wrote it down right underneath, 0.5 to 0.8. Nobody X that out. You don't need that, but you two do. Okay. The rest of the world goes off of 0.8 to 1.2, and so does ATI. Okay.
Okay.
Cool. Cool.
So,
All right.
but we're
Second.
going over 0.5 to 0.8. Okay.
Second thing, pharmacokinetic thing you need to know about Dig. It's an albumin bound drug. What'd you learn about that? What is albumin like? Albumin likes ass. Albumin likes ass. We know that digoxin obviously is an acidic drug. What happens when a drug is albumin bound?
It attaches.
All right, so albumin attaches to this drug, and then what?
So less drug availability?
Yes, there's less drug availability, right? Because whatever is bound to albumin is not working. Only the free drug is working. So what do we need to do before we give a patient digoxin?
Take their blood pressure and
Y'all, hold on, go back. This drug is an albumin bound drug. So what do we need to do before we start them on digoxin?
take their blood levels
Of what?
of their albumin.
Yes, we're going to draw albumin levels, because what happens if their albumin levels are low and this is an albumin bound drug?
Then it's gonna go lower.
They're going to go into toxicity, because if there's less albumin, then that means there's more free drug around, and they're going to go
Then
toxic on digoxin.
For their body.
For their body, yes. Okay, and what's a normal albumin level?
0.8.
No, albumin level 3.5 to 4.5. It's pretty close to same as potassium. After the break, y'all went way downhill. What has happened? What'd y'all do? Did y'all forget to walk around? Did you not eat? Are you hypoglycemic? I ain't giving y'all no more breaks because y'all came back retarded. All right. So I'm gonna have to crop that out. All right. The antidote. There is an antidote to digoxin. Digibind. That's easy. It binds to the yeah. Now that's the brand name. The generic name is Fab antibody fragments. Fab antibody fragments. There is an antidote. All right. So digoxin can treat heart failure. It can also treat chronic AFib. What's AFib? What's your atria doing? Now y'all can say atrial. So if it decreases heart rate, it's going to slow that down and make it squeeze better, which makes sense, right? All right, digoxin is highly excreted through the kidneys. That makes sense. Yes, it's not kidney toxic. I did not draw kidney on here, but you do need to watch kidneys, right? Because it is excreted through the kidneys. Okay. All right. Biggest side effects you will see, side effects you'll see of digoxin would be bradycardia. That totally makes sense because it decreases your heart rate. So they might feel dizzy, lightheaded, have some palpitations. Now, at what point would I treat the bradycardia?
90/60.
Bradycardia. What is the first thing we do for bradycardia? Check for signs of poor perfusion. If they're totally chilling and they have no signs of poor perfusion, what do we do? They have no signs of poor perfusion. They are perfusing fine. What do we do? Yo, if your patient is normal, what do? Nothing. You do. Are y'all okay? Okay. So if the patient does have signs of poor perfusion and they're bradycardic, what do? No. Okay.
If they do have poor perfusion,
They have signs of poor perfusion and they're bradycardic. What drug are we going to give?
atropine.
Atropine, because atropine increases the heart rate. Okay. I have said nowhere in here about blood pressure. Have I even mentioned blood pressure? No. Digoxin does not do anything to your blood pressure, right? Okay. You're with me. All right. Let's go to adverse effects right underneath that. Okay. Dysrhythmias up until AV block. What do we say the AV block was?
Where it blocks from the atrium and the ventricle.
So the atrium and the ventricles are not talking to one another. They may get a little confused or agitated because you're starting to mess with their cardiac output. Okay. All right. Big points that you need to know are interactions. So if you do digoxin plus diuretics, like let's say, let me go back for a second. What does digoxin bind to be excreted?
No.
That is not what I said.
No. Digoxin binds to sodium?
That was lithium.
No, that's
Lithium binds to sodium to be excreted. Digoxin binds to potassium to be excreted. So digoxin requires potassium to be excreted. So what happens if your patient has hypokalemia? What's going to happen to your patient? There's not a lot of potassium. So they're going to go into digoxin toxicity because there's not enough potassium to bind to, right?
Because diuretics lowers the potassium.
Yes, and diuretics lower your potassium. So if they're taking, let's say, furosemide and digoxin, what do you have to be careful of? What does furosemide do to your potassium? It decreases it. And then hypokalemia makes you go into Digtox. So we give them together all the time. It's very common to give furosemide because it gets rid of the fluid, and digoxin, which makes your heart pump better. Okay, those are given together all the time. But you have to watch for Digtox because it is going to bottom out the potassium.
So
Do we understand?
Is there a way to go around preventing that somehow?
Preventing the hypokalemia?
I mean, the toxicity from happening?
Yes, we usually put them on a potassium supplement when they're on Lasix. Almost always we put them on a potassium supplement.
So what
Yeah.
would you tell a patient if they're at home?
Mhm.
Like, what are these signs?
Yeah, sure. So if a patient's at home and they're taking furosemide and digoxin, first I would say increase the potassium in your diet. Okay. I would also say take some salt substitutes because those have a lot of potassium in them, right? And then as far as Digtox, hold on to that because I'm about to cover that. That is probably one of the most tested on things in Pharm, ATI, and NCLEX. So hold on to that for just a minute. Okay, so if you give digoxin and diuretics together, you have to watch for Digtox. We understand that. Yes? Okay. And then digoxin is going to interact with a million different drugs because it's somewhat of a P450, but it can work both ways. So EES is erythromycin. Do you remember what erythromycin is? It's an antibiotic. Which drug class was it in? Which drug class? Erythromycin is in which drug class?
No.
That is not even a thing. Which drug class is erythromycin in? Azithromycin, clarithromycin, and erythromycin are all MAC aced the pad. Macrolides. All right, so you got that. Quinidine, you don't really need to know that. It was just listed, so I put it down. You don't really need to know much about that. Omeprazole, y'all know that one.
Antacid.
It's a PPI. Amiodarone,
Oh, the
weed for the heart. Verapamil, we haven't had that one yet, but that's a calcium channel blocker, and that's what CCBs stand for. Insulin, y'all know that one. And then captopril. What are our prils? Right. So just know that I don't know if they'll ask you specifically those. I just listed them because they were listed. But just know that digoxin does interact with a lot of drugs, other drugs, and so you do need to watch it. Okay. Now I want you to go over to the box right next to that. This is very, very, very important. Okay. So you see above that where it says digoxin toxicity. So we've got digoxin toxicity. Digoxin binds to what to be excreted? Potassium. Okay, so hypokalemia can make you go into dig tox. There are 3 sets of signs and symptoms for dig tox: 1, 2, and 3. Okay, we want to catch it at 1, obvi, right? If you don't, they're going to go into 2. If you don't catch it then, they go into 3. Okay, so the first signs and symptoms of dig tox, this is one of the most tested on things I think I've ever seen. Okay, is nausea, vomiting, anorexia. Remember, I think I've told y'all this in here before. Anytime they ask for signs and symptom of something, it's never in the same body system. Have we talked about that before? Yeah. Okay. So digoxin is a heart drug and it causes GI side effects as the first sign and symptom of dig tox. Yeah. Okay. They also may feel a little more tired. If we don't catch at that point, which a lot of people don't, because when you're in the hospital, people feel kind of pukey and they don't feel like eating. But here's a kind of question you might see so that you're clued in. You have a patient that is, let's say, a 70-year-old patient diagnosed with congestive heart failure. They've been placed on digoxin and furosemide. Okay. You're the day shift nurse. Okay. You go in to check on the patient. He's got his lunch tray and you notice he didn't eat any of it and he didn't eat his breakfast either. And they're like, what would you do? Continue to monitor, report to the physician. Like, what do y'all care that he hasn't eaten? That's what they want you to do, is to assess the digoxin level, knowing that, ooh, he's not hungry, and it sounds stupid. Or they may put it in a priority question. That may be more what you see. You have 4 patients on a cardiac unit, right? You have a patient that has increased ICP with a history of dysrhythmias on mannitol, who now has crackles. Okay. You have a patient on HCTZ with a potassium level of 3.4. I don't like low potassium, right? Okay. You have a patient with heart failure on digoxin who refused his breakfast. Everybody cancels that out. They're like, that's stupid. Who gives a crap? But that's his first sign of dig tox. Do y'all see what you need to be looking for? Yes. Okay. If we don't catch it at the first one, then we go into the second one, which is visual disturbances. They may see halos around lights. They may see a green or a yellow type hue around lights. Okay. Yeah. That's a big one. So visual disturbances is number 2. If we don't catch it at that point, then we progress into the third stage, which is bradycardia, which you kind of saw coming because dig decreases heart rate, and a full AV block where the top is not talking to the bottom. Okay. And that can be bad because then the top can be like bum, bum, bum.
Not going anywhere.
Bum. And it goes when it wants to. Okay. Your cardiac output could really, really get a problem there. All right. So before giving digoxin, we're going to check our daily serum levels. What's a normal dig level? 0.8 to 1.2 or 0.5 to 0.8, depending on who you are. Check their potassium levels. What's a normal potassium level? 3.5 to 5, not because digoxin does anything to potassium. It doesn't. It just requires potassium to be excreted. Very good. We need to check the albumin levels. How come? Because albumin. Digoxin is albumin bound. Okay, so if they have low albumin, they may go into dig tox. Okay, what's a normal albumin level? 3.5 to 5 or 3.5 to 4.5. You need to take their heart rate for 1 full minute. Remember, we hold for heart rate less than 60. Okay. Managing toxicity. What do we do if they start to get toxic? Well, we're going to watch their levels. We're going to watch for nausea, vomiting, anorexia. Those are our first signs. And then remember, there is an antidote that is called Digibind or Fab antibody fragments. Okay. Now for kids, you're going to hold if the heart rate's less than 70 because kids have higher heart rates than we do, right? Mm-hmm. And if they're infants have way higher heart rates than we do. So you would hold for less than 90. Okay. All right. Nursing care. Obvi, we're going to do daily weights and eyes and nose. We're going to watch their EKG. We're going to watch their kidneys, not because it's toxic, but because it's excreted that way. Be careful giving dig with insulin. Why would I do that? Why would I be careful? What's the problem?
It opens the door.
It opens the door to the cell, making potassium go in the cell, which can cause you to go hypokalemic, which can then makes you go into dig tox. Oh my God, that was really smart of y'all. Oh, thank God you picked back up. All right. If they are also on a diuretic, we will put them on a potassium supplement so that they don't go hypokalemic. Okay. And we'll initiate a high potassium diet. Okay. Report. Now, it doesn't usually change. well, yeah, it does. You may not always see a heart rate less than 60, but if it does, you need to report that. If their albumin is less than 3.5, report that because
And then
they
Don't
can
want
go
to go
toxic.
to toxic.
Potassium less than 3.5, why? They can go toxic. If they have nausea, vomiting, anorexia, warning sign of toxicity.
So what
Okay.
is this bottom called? Just like nursing care?
Bottom of what?
Like the categories kind of cut out on the
Oh, I
line.
didn't really write. I mean, this is just like stuff you need to know about
Oh,
it.
okay.
Yeah, these
Okay.
are just stuff you need to know. And then it may require an initial bolus dose. Okay, so just to get you up into therapeutic range, because remember it's got narrow, you may need to give that larger bolus dose. Remember how we talked about how we want it to be right in the middle? Okay. And you may need to decrease the dose in renal patients because it is heavily excreted through the kidneys. Okay. And then if you look right here, I gave you all big key giant points. Like if you're right about to go into the exam or something and you just want to get the big giant key points. Okay. Digoxin does two things. Don't look at your paper, look at me. Digoxin does two things. It increases contractility and decreases heart rate. It has a narrow therapeutic index. It is, what other pharmacokinetic thing did I tell you all about it? It's albumin bound. What can cause dig tox?
Low albumin.
Low albumin,
Low
low
potassium.
potassium. What's the antidote?
Digibind.
Digibind. Hold if the heart rate's less than
60.
60. And if they're on a diuretic, what supplement are we going to put them on? Potassium.
Potassium.
Boom. We're done.
Good job.
Okay.